Okay, so my case study was on a patient with Myasthenia Gravis, and that is an autoimmune chronic disease causing weakness and rapid fatigue of any of the muscles under voluntary control. And it's caused by the breakdown in normal communication between the nerves and muscles. So I'll refer to Myasthenia Gravis as MG just to avoid mispronunciation, which I'm sure I would do if I continue to say it over and over again. But anyways, so more terminology. Neuromuscular junction is the synapse between a motor neuron and skeletal muscle leading to contraction of the skeletal muscle. And this plays a role in the pathophysiology, which I'll talk about in a bit, of MG. And then acetylcholine is the neurotransmitter carrying signals across nerve synapses from neurons to muscle cells, which in the end stimulates the muscle contraction itself. And then IVIG is an antibody treatment that was used on this patient and was used in the treatment of MG and also other autoimmune disorders. And then another, Rocephin, is a type of antibiotic that is used to treat severe life-threatening infections, which this patient acquired during his treatment. And then leukopenia is the decrease in white blood cells, which possibly in this patient's case was due to the prednisone or Imurin that he was on. So just some information on MG. I didn't know much about it. I knew it was an autoimmune disease, but I had to do my research about it. It often presents with muscle weakness and fatigue. That's the main kind of symptom. And then other symptoms are your difficulty chewing or swallowing, taking medicine. It's another initial sign. And then it usually takes a progressive course. Maximum weakness occurs in the first year for most patients, and then you're managing it from then on out with a few outbreaks. So when it's treated, it goes from its active stage to an inactive stage more quickly, and that is what happened with this patient that we'll talk about. And then in the active stage, the symptoms are fluctuating over short periods of time, and then they progressively get more severe, and then hospitalization will occur. After 15 to 20 years of diagnosis, fatigue becomes in a fixed location, whether that be in your face, in your limbs. It really just depends on the patient. Things that kind of trigger or worsen MG are emotional stress, pregnancy, menstruation, specific drugs, hypothyroidism, which more information about that can be in the article that I had you guys read before this, which I thought was interesting. And then increases in body temperature are all factors that can worsen the onset of MG. So normal physiology, a contraction of a skeletal muscle occurs by stimulation of the synapse of a motor neuron. So this picture is kind of small, but when a nerve impulse reaches the axon terminals, the acetylcholine, the neurotransmitter, is released and it attaches to the receptor. And then sodium ions will rush into the muscle cell and potassium ions will diffuse out of the cell. And the interior of the cell will end up having more positive ions, which this results in an action potential. And the action potential is what conducts the impulses across the cell. So this eventually is what causes the contraction of a muscle. So the image in the corner here is a normal neuromuscular junction showing the presynaptic terminal with the motor and nerve ending. So this is what normally should happen in the contraction of the muscle. However, in MG, there is a problem with the acetylcholine receptors, and the concentration of these receptors on the presynaptic terminal are reduced, and this causes antibodies to attach to the membrane. And again, the acetylcholine receptors are reduced further, and this causes the membrane to be less sensitive to acetylcholine. So This was hard for me to wrap my head around, but in patients with MG, your acetylcholine, you might have enough of it. However, the membrane is not as sensitive to it, so it's not producing an action potential, and this is causing muscle weakness. And this picture is just a sign of what can happen: drooping of the side of the face, limited gaze, and elevation of the eye. That was an interesting picture. So some evidence-based recommendations currently. I'm gonna butcher how to say this, the cholinesterase inhibitors, which causes acetylcholine to accumulate at the neuromuscular junction. This was not used on the patient, but this is often used on patients with MG. Surgery, thymectomy, is more so in younger patients who are earlier in the disease course. You don't really see this in older patients, which is what I read. And then corticosteroids, which is what this patient ended up being on, which is pretty much to help relieve symptoms and increase strength. And then immunosuppressant drugs, again, helps with symptom management. This patient was also on some immunosuppressant drugs. Plasma exchange can be used. It's a short-term intervention, which can initially cause worsening of symptoms, but in the long term can reduce the likelihood of an onset or an outbreak occurring again. And then this IVIG was the main treatment used on this patient and is the most common treatment because it is the most easily administered, it's the best tolerated, and it's the lowest cost for hospitals. And this downregulates antibodies against the acetylcholine receptors and causes pretty quick improvement, which we saw in this patient. All right. So the multidisciplinary team, the neurologist is always involved. Chest surgeons, if there is any type of surgery, might be involved. Endocrinologist, always involved. Speech therapist, for the most part, working closely with the dietitian, because most patients with MG will have tube feedings of some sort because their swallowing is impaired. And then pulmonology, usually involved as well. So some alternative therapies, respiratory muscle training. There's some research behind breath training in people with MG, working with pulmonologists as well, help increase their endurance, which I guess causes them to use less energy when they're breathing. The training of this will aim at improving and strengthening the muscles that help you breathe, again, to reduce the work that your body has to put forth. Some other recommendations are to eat small, frequent meals, especially in patients who have problems with chewing and swallowing. A modified diet might be necessary. And then focus on pretty much a healthy diet to avoid muscle wasting and weight loss, because weight loss is very common in patients with MG. And then to eat foods rich in calcium, vitamin D, and potassium, and these nutrients are often low in patients with MG. And then antioxidant supplement to avoid oxidative stress is another recommendation that can be done. There was one study that showed the effectiveness of this. So on to the patient and case study. So this patient was admitted on March 2nd with a primary diagnosis of MG and secondary to upper respiratory infection. He had a medical history of hypothyroidism, right carpal tunnel syndrome, arthritis, prostate problems, chronic back pain, hernia surgery, and hip replacement. He was morbidly obese. He was 65 years old. He didn't appear 65 years old. He appeared younger than that, and from looking at him, he didn't look morbidly obese to me, which I thought was interesting. And then there are some of his vital signs. So some of his labs. I'm not going to go through all of these, just for the sake of time. But the main one that is important is the leukopenia, the low white blood cell, which stayed pretty consistent throughout his time at the hospital, which was a huge concern. And then another one I spoke with my preceptor about is that all of his nutrition-related labs, his sodium, his calcium, his potassium, his chloride, and phosphorus were all normal, which was a sign that we could tube feed him, and we didn't have to. I mean, we were watching out for refeeding syndrome, but it was a good sign that those were all normal, which was also very odd for a patient with MG. His glucose was normal. His creatinine was a little low. Could be some kidney things going on there, but the main one that we were focusing on was the nutrition-related labs. Dietary data, unfortunately, I wasn't able to get a very detailed history of this man. He was ventilated for most of his time, and then when he wasn't ventilated, he didn't really say much. So I spoke with his wife a little bit, and I know he lost 20 pounds since his diagnosis in December, so that was 3-4 months prior. And his appetite was severely decreased since his diagnosis of MG, and he ate about 1 meal per day, and some things that his wife mentioned were soups, frozen dinners, cereals. Didn't sound like they had any time to cook, so I think it was a lot of processed foods, but like I said, I unfortunately wasn't able to gather much information about his diet history. His medications, I won't go into detail about much of these. However, he was on insulin. He wasn't diabetic, which was also surprising to me since he was morbidly obese, but he was on insulin due to the corticosteroids that he was on. And then he was taking acetylcholine as well as part of his IVIG therapy. He was on propofol, which we needed to keep in mind since it provides some calories. So when we were coming up with his tube feeding calculations, we needed to keep propofol in mind, and that was constantly changing. So the current medical treatments that this patient was on was IVIG, like I said, which is antibodies that are extracted from healthy people and they're put into the vein of the unhealthy patient. And this patient was ventilated due to increased respiratory distress and secretions in the throat. He eventually had an NG tube placed. He was MPO and wasn't eating for days. So this was a big kind of push. And then he was being provided a pulmonary toilet, which is what this picture is here at the bottom. And it was to clear the mucus and secretions from the airways. And this is where pulmonology was really important in his treatment because he had a lot of secretions. Again, the multidisciplinary team mainly was neurology, pulmonology, speech therapy, and nutrition came into play when he started his tube feedings, and then this patient was eventually off ventilation, so we were able to advance his diet a little, and again, we were working with speech quite closely. So his current diet order, well, he initially, 2 days after he was admitted, he was intubated, so he was on isosource 1.5 at an initial rate of 15 milliliters per hour. He was having IVFs at 100 milliliters per hour, so we didn't do any additional water flushes, and we wanted to keep this rate for at least 12 hours to just assess his tolerance and make sure there wasn't any refeeding going on. And so we were keeping a close eye on his labs during that time. So the following day, he was still intubated. We increased his rate to 30 milliliters per hour. We also added Promod just to increase his protein. The isosource wasn't providing adequate protein that this patient needed. and especially since this wasn't at his goal rate yet. So he was continuing to receive IVFs as well, so we didn't do any water flushes. And then further advancement of his diet was done about 4 days later. He was tolerating everything very well. It was miraculous. He was the talk of the ICU, honestly. He was extubated 4 days later with updated energy protein requirements. We increased those. He was still receiving his tube feeding just because he was a little out of it. He was still wasn't able to swallow. So we upped his rate to 45, and we added the water flushes, 150 milliliters Q6, so that we could eventually increase the goal rate to 60 milliliters per hour if the patient was tolerating, which he was. So about a few hours later, he was at his final goal rate for about 4 days, and then the NG tube was removed. His diet was further advanced to just a diabetic with chopped meats, just due to some swallowing difficulties still. It was quite amazing how quickly he recovered, and it isn't common for MG patients that had an outbreak like this to recover as fast as this man did, so it's pretty crazy to see. So his initial assessment, so as I said, he had BMI of 41, he was morbidly obese. He had a recent weight loss of 20 pounds since his diagnosis of MG. There were no signs of malnutrition despite the recent unintentional weight loss. That was quite significant. The patient, as I said, he usually eats well with good appetite, but since his diagnosis, he hasn't eaten much, maybe 1 meal a day. And then just some client history. This guy's kind of had a tough run. He was diagnosed with Lyme disease about 20 years ago. About 15 years ago, he was diagnosed with spinal stenosis, chronic hypothyroidism, which plays a role in the onset of MG. And his diagnosis ended up being inadequate energy intake related to progression of myasthenia gravis, as evidenced by recent reports of skipping meals and report of 20-pound unintentional weight loss. And then we also, talking to my preceptor, we also came up with another PES statement as inadequate vitamin and mineral intake related to inadequate oral intake, as evidenced by abnormal lab results and the diagnosis of hypokalemia and hypomagnesia, which was during his initial admit. He had hypokalemia and hypomagnesia, but this was quickly turned around. Interventions, nutrition interventions. So we began tube feeding as soon as possible. We started the feeding rate low just to assess his tolerance and to avoid refeeding syndrome, since this man hasn't been eating well and then he didn't eat for a few days prior to admission. We were increasing his tube feeding rate as he was tolerating it and as ordered by the MD. We provided a ProMod, which just to increase his protein and to promote healing. We were considering multivitamin to meet his RDIs, since we didn't get him to his goal rate until day, I think, 7. And then we were, again, advancing his diet as recommended by the MD, which ended up being diabetic diet with chopped meats. So monitoring throughout his stay, what we were monitoring were his residuals. So he didn't have any residuals, miraculously again. We were able to increase his tube feeding rates as planned because he was tolerating them so well. His labs, of course, we were watching his potassium, sodium, magnesium, and chloride to assure that these were repleted before increasing the rate to avoid refeeding syndrome. We're keeping track of his bowel movements, just again to assure tolerance. We were watching his weight with the goal of no further weight loss, and we were staying in close communication with the SLP and doctors to advance the diet as necessary. So the progression of his case, he was admitted on March 3rd. He was intubated and sedated immediately, pretty much. He was receiving propofol, and he was reported chronic diarrhea prior to admission due to the medications that he was taking. He had a Braden score of 20, so he wasn't at risk for a pressure ulcer, but he had inadequate nutrition reported. And then there were no tube feedings as of yet. They were waiting, so we were waiting the diet to be advanced. The doctor's main concern was that he had diarrhea, and a lot of the doctors like to blame diarrhea on tube feeding, so there was an initial kind of pause in tube feeding orders. So the following day, the patient was intubated and sedated. He was still receiving propofol, which was providing him 606 calories per day. Towards the end of the day, the doctor ordered some tube feeding to be initiated after the NG tube was placed. So they first tried to place an OG tube, which was unsuccessful, and we weren't really provided much information about why they placed that and why it was unsuccessful. I think they just wanted to get him fed as soon as possible, but it was unsuccessful. So the NG2 was then placed very late in the evening, and he was initially started at 15 milliliters per hour. As I stated before, this was only providing 540 calories and 24 grams of protein, but we wanted to avoid refeeding. So the doctor was planning on increasing it in the morning. And the next day, there were 0 milliliters residual reported, so the patient was tolerating the tube feeding well. His diarrhea actually subsided a little, and we increased his feedings to 30 and added that Promod. So 3 days later, the patient was extubated. Amazingly, again, this was just the talk of the ICU because this patient just really responded so well to the tube feeding and to the IVIG treatment. So we had some updated energy and protein requirements due to his extubation, and his feedings were now being increased to 45 milliliters per hour with water flushes. And then if the patient tolerates well, they were going to increase to goal rate. However, the next day, the patient's NG tube was removed, and there were no longer tube feeding orders. His diet was to be advanced to diabetic with chopped meats and extra sauce. So when we came into the office this day, it was like reading this note was amazing to us. We didn't expect his diet to be, we didn't expect his tube feedings to be done this quickly. So then by his last few days, his labs were all relatively normalized. The patient was progressing remarkably well, and he was expected to be discharged just 4 days after the NG tube was removed. He was eating well with his advanced diet, with intake reports of 150, 100, and 100%. So he was hungry, and I spoke with him a little bit, and he said his appetite was improved so much since before he was admitted, and it showed in how he was eating. He no longer had any real chewing or swallowing problems, just the chopped meats were the one modified thing that the SLP recommended. So when I did talk to him, he was very alert, he was pleasant, he was so eager to go home, and very thankful for the nutrition staff. And he made a note when I talked to him that nutrition was, he was very impressed with them and very thankful. So that was just cool to have that conversation. So conclusion and areas of improvement. So this was a pretty complicated case. I think, and like autoimmune diseases are so interesting, and a lot going on. He was He was NPO, he was then intubated, he had an OG tube placement failure, and then an NG tube placement, tube feedings. He was then extubated, and then his diet was advanced. So he just was all over the spectrum of where nutrition and dietitians can play a role. So that was really neat to be a part of. The patient, as I've said, responded remarkably well to medical treatment and the tube feeding, and I think nutrition intervention played a crucial role in this patient's progression and in his recovery. He came in pretty sick, and once those tube feedings started, I mean, he improved every day that he was in the hospital. So it really took a multidisciplinary team every day to go at this patient and help him through his treatment, which was also cool to be a part of. Again, as I said already, the patient expressed great gratitude for the medical staff and nutrition specifically. Areas of improvement, there wasn't anything that I specifically would recommend to improve. I think communication between doctors and dietitians can always be improved. Sometimes we felt like we were the last to know things when we were playing such an important role in this patient's progression. So that's one thing that I would say is to keep dietitians in the know, which I'm sure a lot of you can relate to. Other than that, that is my case study, and these are my references. Thank you.